Welcome to today's podcast on the endoscopic resection of a laterally spreading tumor, LST, in the ascending colon. We will be discussing a case where a flat polypoid lesion larger than 10 mm was identified, classifying it as an LST. The initial steps for planning an adequate resection include determining the lesion's location, which in this case was found between two folds. The morphology was analyzed and identified as LST-granular. A close-up view with high-definition white light and narrow-band imaging was used to analyze the surface, revealing a regular cerebroid mucosal pit pattern without ulcers or depressions, classified as Kudo IIIL. The vessels appeared regular and without deformities. A crucial tip is to not lose sight of the polyp during the procedure. A useful technique in challenging situations, such as a highly mobile colon or presence of debris, is creating a suction mark next to the polyp. This is done by pushing the scope towards the lesion and suctioning the mucosa, leaving a red submucosal mark that aids in relocating the polyp. There are various approaches to resecting flat lesions. While some experts prefer the cold snare technique, others opt for hot snare. Our preference is endoscopic resection using interventional chromoendoscopy. This method is chosen because the LST has an irregular, almost triangular shape, is located between folds, and we aim for an R0 resection, which means removing the tumor entirely without burning or ablating the edges incompletely. The LST is raised using a submucosal injection with a blue colorant, such as Elavue or a mixture of normal saline with indigo carmine or methylene blue. This helps in differentiating normal from preneoplastic or neoplastic tissue and facilitates a more sessile appearance of the polyp. During resection, the snare is used to estimate the lesion's size, which in this case was approximately 12 mm. A submucosal cushion allows for the complete entrapment of the LST above the snare. By tightly closing the snare and applying electrosurgical current, an endoscopic R0 resection is achieved, ensuring no vertical or lateral tissue is left behind, which is a risk with cold snaring techniques. Given that this LST was in the right colon and the patient had hypertension, both risk factors for post-polypectomy bleeding, prophylactic clips were used. This decision was based on the patient's individual risk factors and the outpatient nature of the procedure, emphasizing the importance of personalized endoscopy over strict adherence to guidelines. When placing clips, it's advisable to minimize insufflation to keep the area small and check the placement after clipping by using a little air. This concludes our discussion on the endoscopic resection of an LST in the ascending colon. Thank you for listening.